Okay. Well, we are here for the Q&A session. This is Dr. Pierre Cloutier, all the way down from Canada. Although he's a world traveler, he's going everywhere. El Salvador is next. So I host these Q&As to answer questions that we commonly get from patients. And some of the common ones that we get oftentimes revolve around what we've been talking about recently is the spike protein and how it affects people who have not been vaccinated. So what are some of the symptoms someone might get if they are experiencing spike protein shedding?
What I think?
Yeah.
You have experience with that too. Some people, they get tired, so it's difficult to pinpoint a specific symptom, but most of this is like tiredness. They don't feel like doing nothing. They go to the gym, but they are not interested, and it takes a few days, and then after that, they get better. So that's what I have seen.
Yeah, and how are you treating it? Any medicines in particular?
Some people say they are better when they take ivermectin, like a couple of times a week, not necessarily every day, but a couple of times a week.
Yeah.
And maybe hydrogen peroxide in nebulizer. This seems to improve the symptoms.
Yep. I use the ivermectin prophylactically for people who are sensitive to the spike protein. Some are more sensitive than others, and I'm not clear why some are so sensitive. Mm-hmm. I've never experienced it, but I know people who have experienced it. Mm. Now, you told me something very interesting recently when you studied the initial H1N1 influenza virus. You saw that it depletes the cortisone or cortisol. Mm-hmm. So your theory is to just give them back a physiologic dose of cortisol at the onset of the illness, and that will enable you not to have to use high doses later. Mm-hmm. So a physiologic dose is approximately 30 milligrams a day, right?
Of hydrocortisone?
Hydrocortisone.
Yeah. Or if you prefer to give like prednisone, like 5 to 10 milligram a day.
Uh-huh.
Yeah, 10 milligram a day. Like prednisone 5 milligram twice a day would be a good dose to when somebody have a influenza. Yeah. For 3 or 4 days, not long.
The dexamethasone is too potent, not always necessary, right?
But if you calculate the dose, like maybe 1 milligram twice a day would be equivalent, something like that.
Oh, wow.
Yeah.
For croup and some infections, like respiratory infections, they'll give maybe 4 or 6 milligram dose. It's a very high dose.
Yeah.
And it knocks it out. It's very strong, but you can get some psychological side effects from it. Mm-hmm. Yeah. And you can't use it too long, and you need to taper it if you use that. Yeah. But the hydrocortisone, people have to understand, is different. It's natural. You're just giving back the body what it physiologically would produce. Mm-hmm. And it's a great hormone replacement therapy as well for people with low cortisone.
Yeah.
What might be some symptoms of the low cortisone?
It's tiredness. That's, the main symptom of low cortisone is you are tired.
Yeah.
It's like an example, when the kids, after dinner, they are very excited, they cannot control themselves. What is the best thing is put them to sleep because they are low in cortisol. If you would give just a little, like a 2.5 of Cortef, hydrocortisone, they would be quiet. So the treatment of low cortisol when you're tired is to go to bed and sleep, and then you replenish the cortisol. But if somebody is low in the morning, you can give a little supplement. When you give a little supplement of cortisol, it always has the side effect of lowering the DHEA. Mm-hmm. So you have always to be sure if somebody will take cortisone in low dose for a long time to give DHEA.
Right.
At 25 milligram a day for a woman, 50 milligram a day for men.
All right.
Average.
Do you ever supplement with pregnenolone as well?
Yeah.
Yeah. That's good precursor of cortisone.
Yeah. Because when you supplement of the two basic hormones, I would say it's DHEA, that will go on the testosterone and estrogen side, and pregnenolone will go on the cortisone and progesterone side. Mm-hmm. So then you have like quite a good hormonal supplement that is over the counter and cheap.
Well, I take it as well every day. I take pregnenolone, 100 milligrams, and I take DHEA, only 5 milligrams. Because otherwise I get acne on the back.
Oh, see, that's a sign that's too much.
Too much oil.
Yeah. But you're like 16 years old again, so it's too young for you.
Right, yeah, but it's not as high as it was. I think when I was younger, it was much higher because I had bad acne as a child.
Yeah.
And so I think my DHEA was high. Because when I test teenagers, their DHEA level was like 500.
Yeah. That brings us to an interesting point. People, they like to have a blood test. They say, I'm going to take this, or I'll take a blood test to check. But usually when your hormones are secreted, they're secreted all day. And if you do a blood test when you're not supplementing, you get the real thing. Okay? But once you supplement, you take it once a day. And it's a steroid hormone, so it's a little bit in the fat, so it won't stay long in the blood. So you're going to have a peak and a low. And 24 hours after, it will be low again. So a blood test is not a good way to follow a hormonal replacement.
No.
The best thing is to know what that hormone does, and then, so the best thing is like with DHEA, like for a woman, you start at 25 milligram, and if she have acne, then she reduce. But if it does nothing, you increase to 50, increase to 75, and then you see what it does. So once you know your hormones, you don't need a blood test to measure the level.
Right. What do you think of salivary hormone testing? You ever done that?
Yeah.
Do you think it's useful at all?
It is useful, but you have to be well trained in doing an interpretation. Because some hormones, when you take a lot, it will be excreted in the saliva. So then it will look high.
Yeah.
So it is very difficult to make a good interpretation.
I think the same thing. Whenever I've done the saliva testing, it's always super high. And then the patient is scared. I'm like, look, you're still deficient in hormone. The saliva test, we cannot rely on this.
Yeah.
And they get scared though. So I stopped doing saliva testing. I might do it initially, especially if they're premenopausal woman and it's difficult to get them to go to the lab and get testing done on day 19 through 21 to measure the estrogen-progesterone ratio. So I give them the test, they go home, they can do it at home.
Yeah.
And then maybe you can get a decent, accurate look. But if you're taking hormones, especially if you're doing a transdermal, it will always be high. If you do the transdermal estrogen and then you do the saliva test that day, it will be so high.
Yeah. It's high according to the lab reference.
Right.
But I believe a doctor that knows about it and knows his patient and he do it all the time, he get a lot of experience. He say when it's high, it's not really high because he will figure out the symptoms. So I don't say it's not good, but I say that I don't have the experience enough to use it wisely.
Right. I think it's most useful for maybe measuring a 4-point cortisol salivary.
This is good.
Yeah. And you can see, does it come up high in the morning? Does it go down at night? Some patients, they're low all day long. And this isn't good. You don't want to be low cortisol. Everybody thinks cortisone is a bad thing. And everybody talks in functional medicine about lowering the cortisone. But having a low cortisone is not a good time.
Yeah.
You feel pretty bad.
Yeah. I think when they say lowering the cortisol, it's what they mean is lowering the need for cortisol. If you have a stressful life, you need cortisol. So if you reduce your stress, then you don't need as much. So that's the point. But you need cortisol according to the stress you have. If you are high stress and you make high cortisol, you won't be stressed. You'll be happy with that kind of lifestyle. But once the stress is high, the cortisol starts to be low, you find it difficult.
And the patients with autoimmune, especially inflammatory gut conditions, they use up a lot of cortisone. And so they can be chronically fatigued, possibly due to cortisone depletion.
Yeah, because they use it in their belly and not enough for the brain.
Right. That's not a good thing. If we don't get hormones to the brain, you're going to get Alzheimer's. You're going to get bad cognitive issues. So what are the neurosteroids? The hormones that protect the brain. This would be DHEA, pregnenolone, cortisone
at the right level. When there's because cortisol is a catabolic hormone. So if it's high all the time, it will be toxic for the brain. So, but if you have the DHEA and the pregnenolone with it, they are anabolic hormone. So it will compensate. So the cortisol won't be toxic in presence of DHEA. That's what I think.
But all the hormones protect the brain. The estrogen, the estradiol, the testosterone, they're all very important for the brain health.
Yeah.
So they all need to be replaced and optimized to prevent the cognitive issues with time.
And, you know, magnesium, lithium, very important for the brain too.
Right. Lithium has been fantastic. Ever since I read your book, I've been doing so much lithium. It's great for anxiety, depression.
Yeah, I believe it's because people say, if I have anxiety, what should I take? And when we give lithium, it reduces. But I believe it's the deficiency of lithium that creates anxiety. You know, so when you give lithium, you don't give a treatment. You compensate the deficiency, and the anxiety reduces. The way I see it.
Yeah. And the magnesium, especially a form called 3 and 8, I've used it a lot for anxiety. It goes into the brain and they calm down a lot, relaxes them.
Yeah.
Other signs of magnesium deficiency can be like the muscle twitching. That's obvious. Everyone knows that. I mean, some people don't. They have the cramps or they have restless leg syndrome. Restless leg syndrome, I think, is a made-up concept. This is not a real thing. It's an electrolyte deficiency. It's a hormone abnormality. But in the conventional primary, they're going to give them sometimes antipsychotic medications for this. But I don't think it's the right approach.
Yeah, but it's a syndrome. So maybe some people have like, when they have anemia, I think low iron, they can have that kind of leg problem. So it's a syndrome that can be fit, but the definition is too wide. Everybody that have like leg cramps, they put it restless leg.
Yeah.
Like just a magnesium deficiency, it is probably not a restless legs.
It's a catch-all term for
Yeah.
something that's super individualized.
Yeah. Like everything, once you get the diagnosis, you get a treatment with a pill.
Right.
So it's important to fit the patient in a diagnosis.
Right.
So, but if you don't use diagnosis, you will use the cause. So if you figure out and it's a magnesium deficiency and you treat the magnesium deficiency, it goes away. It was a magnesium deficiency.
Yeah. I see that so often in the practice here because when patients, oftentimes they'll come to us and they're used to a conventional model. And the conventional model is very structured. You see the doctor, he needs to meet the criteria for this. So he's going to make the lab test, he's going to do the physical exam. But he's doing all this to check the boxes to meet the FDA criteria to approve the drug.
Yeah.
Well, for me, I come in, I'm like, I don't care about these tests. I want to look at your gut microbiome. I want to look at your vitamins. I don't care if, like patients, they want diagnosis sometimes. This is something that they need to separate themselves from. It's difficult for the patient sometimes. Yeah.
But the cause of the disease is never a deficiency in a medication.
No.
So if you cannot find the cause, the patient is suffering, you give him a medication temporarily while you're looking for the cause. Sometimes you don't find immediately, sometimes it's difficult, but if you don't look for it, you will not find it.
Right.
You have to know what are the cause. And it's not the way we were trained in school. We were not trained to find the cause of disease.
No.
Yeah.
No. It's super individualized for a patient too. One thing may not work for them where it works for another patient. Wow.
Yeah. Very interesting. Like all the Toyota Corollas are the same.
Yeah.
But humans, there's not two alike.
Exactly. We're not made on an assembly line.
To me, a mechanic of the human, it's a very interesting thing.
Yeah.
You have to be humble.
Right. It's all about experimentation too, to see what might work for somebody.
Yeah.
Yeah. No cookie cutter approach.
Yeah.
And good. Let's see if we have any question in the chat. Mom's talking about microdosing older, HRT in older women. So
Microdosing?
yeah, so like low dosing of hormones.
Yeah, it's a good thing.
Yeah.
Yeah. Because you use the smallest dose that works. No need to give more. You know. Usually we start with a standard dose, like bias 2.5. It's a good start. But you know, some women will have too much estrogen with that. You reduce and you find out. Usually the patient can find out, you know, the right dosage for themselves if they don't move the level too quick. You know, if one day she does that, the other day she does, then it's too, because it's soluble in the fat, it stays long. So you have to do like 1 week at one dosage, check the symptoms. After that 1 week, reduce or increase.
My patients are very sensitive. I don't typically start them at 2.5. They're going to get some side effects from that.
Oh, yeah.
I usually might start them with 1 milligram, and then it comes in a toppy click. So each click is 0.25 a milligram. But even that, for some, it's a lot. And I think that's because some haven't had estrogen in a long time, and when you start them, they feel it. My mom is one of those. That's where she's asking this question. She needed a super low dose. But then there's some in functional medicine who say you need to optimize the dose of the hormone to younger levels. And so, like Dr. Felice Gersh, she says you want to see an estradiol in the blood of about 100. And so you need to dose the estradiol to reach that level. She's of the mind that low dosing estradiol is actually a bit inflammatory. And to only get the anti-inflammatory benefits, you need to reach a younger level in the blood.
But when we give bias 2.5, it's 80% estriol and 20% estradiol. So that's 0.5 milligram of estradiol.
Okay.
So that's a good starting dose.
So that's the other thing Dr. Felice Gersh says is she only does estradiol, and her reasoning behind that is estradiol is really only found high in pregnant women.
Yeah.
In the normal physiology, there's not much estradiol. There's estradiol, and when you give estradiol, some of it will be converted to estriol.
Yeah. All right.
But the estriol is supposedly very good for the skin health. So I think.
Yeah, because it's usually in a woman about 80% is estriol and 20% estradiol. That's the physiology. Yeah. So when we replace, we can do the same, or just give the estradiol and it will make the estriol.
Right.
So, but it all depends on women,
Some women, they will get estrogenic side effects because they don't metabolize estrogen correctly. And these may be breast tenderness, nipple sensitivity, maybe they get menstrual bleeding again. Getting a menstrual bleed in a woman who hasn't had it for some time, they're going to come and they're going to be calling me. Yeah. Stefan, what have you done to me? And so Dr. Clearfield, who he just doses progesterone until they don't bleed anymore. So that's what he does. He says it dries them out. Dr. Felice Gersh, she says that we should be cycling the hormones. We should have a woman bleed because it's the fountain of youth. So she has them do cyclical progesterone, day 15 through 27, has them stop it, has them have the bleed, and then has them restart again the next month. Yeah. But this is a hard sell.
Yeah. But it's all good if the woman wants it. Like in the Middle East, the woman, that's what they want, to have cycles. So they ask for it, so you have to figure out the best for them. Here, the woman, they don't like to have period after the menopause, so you reduce the dosage or you increase the progesterone. So it's like
That's right. I always forget you worked in the Middle East.
Yeah, I've been working there.
That's right. It's the fountain of youth. It's considered.
Yeah, but once a woman bleed, like after her menopause, you have to do a biopsy of the endometrium.
Right.
All the time.
If it doesn't stop. Right.
Yeah, but even at the first bleeding, I always did it. I never found a cancer.
No.
So, but it's like
it's a thing you do.
It's like a safe thing to do.
Yeah. Understandable. Or you just dose the progesterone and they probably won't have the bleed. And if you do the lower dose estradiol, they won't have the bleed. If you do high dose estradiol, they're going to bleed at some point.
And it goes with the age of the woman. Like the woman who have their menopause is very young, like 35, 40 years old. Maybe they will need a little more, And if a woman is like 5 years in the menopause and you give her estrogen, you can start very low.
Yeah.
It doesn't need much.
Right.
Because probably the receptors are very sensitive because they try to catch everything that come by.
They're just trying to get a little estrogen again.
So don't put too much because it will be...
Yeah. Let's see what else here. I'm wondering if hormone for older women might be similar to melatonin, that is less is more. Well, melatonin, you don't need very much melatonin.
No. Yeah. What's over the counter, it's for hour change, when you travel in Europe. it's like 3 milligram a day. Usually the 3 milligram a day is what you need depending of the amount of hours. If it's 7-hour change, time change, you take 3 milligram for 7 days. And after that, you go to the normal physiologic dosage that is 0.5 milligram. One maximum.
It's a low dose.
Yeah. And I would say, don't take it every night. You can take it only if you have a problem sleeping.
Yeah.
If you fall asleep without it, you don't need it because you make enough.
It's good enough. Good. All right. Very good. I think we covered everything.
Yeah. You happy?
Yeah, okay. I'm happy. I don't think we got too many people showing up, but that's okay. We got a chance to talk, cover some things.
We got the world listening.
Yeah. All right, thanks, Mom.